video, we will discuss about a complex nerve network of great clinical significance located in the neck. This nerve network is the brachial plexus. It is formed as the anterior rami of the 5th through 8th cervical and 1st thoracic spinal nerves intermingled with one another in the posterior triangle of the neck. It is divided schematically into subparts termed roots, trunks, divisions, cords, and terminal branches. The roots are the anterior rami of spinal nerves C5 to T1. There are 3 trunks. The upper trunk is formed by the unity of C5 and C6. C7 forms the middle trunk, and the lower trunk is formed by the roots of C8 and T1. Each trunk divides into anterior and posterior divisions, which also do not give off branches. The cords are further made up of the lateral cord formed by the anterior divisions of the upper and middle trunks, the medial cord formed by the anterior divisions of the lower trunk, and the posterior cord formed by the posterior divisions of all 3 trunks. There are 5 terminal branches of the brachial plexus: the musculocutaneous nerve, median nerve, ulnar nerve, axillary nerve, and radial nerve. It is interesting to note that the musculocutaneous nerve, median nerve, and the ulnar nerve form a letter M with the distal part of the brachial plexus. To easily remember how the brachial plexus is divided, a mnemonic can be used. It goes, Roger Taylor drinks cold beer. Let's discuss first the branches from the brachial plexus roots. First, we have the dorsal scapular nerve that branches from the C5 root. It supplies the rhomboid's elevator scapula. Next, we have the long thoracic nerve that arises from roots C5 to C7 and supplies the serratus anterior. Trauma to this nerve results in inability to rotate the scapula during abduction of the arm above a right angle, so the patient has difficulty in raising the arm over their head. The inferior angle of the scapula will no longer be closely applied to the chest wall and will protrude posteriorly as winged scapula. The middle and lower trunks do not give off branches. 2 nerves branch off from the upper trunk: the suprascapular nerve, which supplies the infraspinatus and supraspinatus, and a nerve to the subclavius. The suprascapular nerve is important clinically because it may give a contribution to the phrenic nerve.
Now we go to the branches of the lateral cord, where all 3 originate from C5, C6, and C7. First is the lateral pectoral nerve. It supplies the pectoralis major. This is the musculocutaneous nerve. This nerve is first muscular in division and then becomes cutaneous. It supplies the anterior compartment of the forearm and is rarely injured because of its protected position deep in the biceps brachii. But if injured high up in the arm, the biceps and coracobrachialis are paralyzed. The brachialis is greatly weakened and sensation is lost along the lateral side of the forearm. Moving on to the branches from the posterior cord. First, supplying the subscapularis is the upper subscapular nerve. Second is the thoracodorsal nerve, which supplies the latissimus dorsi. Then, the lower subscapular nerve, which supplies the subscapularis and teres major. Next is the axillary nerve. It enters the quadrangular space with the posterior circumflex artery. Throughout its course, it gives off branches which include nerve supply to the deltoid and teres minor. Dislocations of the shoulder joint, compression of the quadrangular space, or pressure of a badly adjusted crutch pressing upward into the axilla may injure the axillary nerve. The deltoid and teres minor are then paralyzed. And lastly is the radial nerve. This is the largest branch of the brachial plexus and the sole motor nerve to the muscles in the posterior compartment of the arm and forearm. It lies deep behind the axillary artery and is accompanied by the profunda brachii vessels when coursing through the radial groove, and finally dividing into superficial and deep branches at the level of the lateral epicondyle. The radial nerve is commonly damaged in the axilla, radial groove, and in fractures and dislocations at the proximal end of the humerus. And since the radial nerve supplies all the muscles in the posterior compartments of the arm and forearm, the patient is unable to extend the elbow, wrist joints, and the fingers. Flexion of the wrist or wrist strap also occurs. Lastly, we tackle branches from the medial cord. First is the medial pectoral nerve from C8 and C1. This mainly supplies the pectoralis minor. Next are the medial cutaneous nerve of the arm and the medial cutaneous nerve of the forearm. Then there is the ulnar nerve. It does not give any cutaneous or motor branches in the axilla or in the arm. It is accompanied by the superior ulnar collateral vessels as it pierces the medial intermuscular fascial septum. Its branches include muscular branches that supply the flexor carpi ulnaris, the ulnar half of the flexor digitorum profundus. Injuries of the ulnar nerve at the level of the elbow are usually associated with fractures of the medial epicondyle. The superficial position of the nerve at the wrist makes it vulnerable to damage from cuts and stab wounds. Injury to the nerve may present with what we call as ferment sign. Flexion of the wrist joint results in abduction, and the medial border of the front of the forearm results in flattening. The patient is unable to adduct and abduct the fingers and is consequently unable to grip a piece of paper between the fingers. Adducting the thumb is also impossible. Another clinical picture that would present following ulnar nerve injury is when the metacarpophalangeal joints are hyperextended, most prominently in the fourth and fifth fingers, while the interphalangeal joints are flexed. The hand assumes a claw hand, papal hand, or main-on grip, with the clawing most prominent on the ulnar aspect. Unlike median nerve injuries, lesions of the ulnar nerve leave a relatively efficient hand. And
fifth and finally is the median nerve, arising from the medial and lateral cords. It is so named because it mainly runs along the median axis of the upper limb. Like the ulnar nerve, it does not give off any cutaneous or motor branches in the axilla or the arm. It leaves the cubital fossa by emerging between the two heads of the pronator teres. It enters the palm of the hand by passing deep to the flexor retinaculum and through the carpal tunnel, emerging as a minor motor nerve to the intrinsic muscles of the thenar compartment. Through its course, it gives off several branches that supply the wrist. Supracondylar fractures of the humerus and more commonly penetrating wounds proximal to the flexor retinaculum can cause injury to the median nerve. The pronator muscles of the forearm and long flexors of the wrist and fingers are paralyzed. As a result, the hand looks flattened and is often referred to as ape hand. Skin sensation is lost on the lateral half or less of the palm of the hand and the palmar and distal dorsal aspect of the lateral 3.5 fingers. Skin will be warmer and drier than normal due to the arteriolar dilation and absence of sweating. Skin will be dry and scaly, nails crack easily, and the pulp of the fingers will atrophy. It is also important to tackle briefly some clinically important injuries involving or related to the nerves of the brachial plexus. Let's begin with upper lesions of the brachial plexus and the Herb Duchenne palsy. Herb Duchenne palsy involves excessive traction or even tearing of the C5 and C6 roots. As a result, the limb will hang limply by the side, medially rotated by the unopposed sternocostal part of the pectoralis major, and adducted because of the loss of the supraspinatus and deltoid. The forearm will be pronated because of the loss of the biceps. This is more commonly referred to as the waiter tip posture. Next is Klumpke's palsy and lower lesions of the brachial plexus. These lesions are usually a result of traction injuries from excessive abduction of the arm and can also be produced from the presence of the cervical rib or malignant metastasis from the lungs. The T1 ramus is usually torn, As a result, the hand has a clawed appearance caused by hyperextension of the metacarpophalangeal joints and flexion of the interphalangeal joints. Loss of sensation will occur along the medial side of the arm. This is more commonly known as claw hand deformity. Lastly is the carpal tunnel syndrome. Any condition that decreases the size of the carpal tunnel and compresses its contents can cause the syndrome. This causes thickening of the synovial sheets of the flexor tendons or arthritic changes in the carpal bones. Compression necrosis is a major possible consequence. The nerve compression consists of a burning pain or pins and needles sensation along the distribution of the median nerve to the lateral 3.5 fingers and weakness of the thenar muscles.